Hi, my name is Lauren Perlman, and I'm here at Boston Children's Hospital today. We're going to look at and help you use and learn to use the LTV laptop ventilator, formerly known as the Pulmonetics, but now purchased by a company called Viasys. Most people just call it LTV or laptop vent, due to its size and shape, I'm sure. There are several models of this ventilator available. In the hospital, we use the model 1200. And that is because that model allows us to hook the wall oxygen that we have at 50 pounds of pressure directly to the ventilator and have a blender so that we can look at oxygen in the hospital in percentage of 21 up to 100%. You can't do that at home because you don't have that type of oxygen delivery at home. At home, you have oxygen that's run by liters per minute out of a tank source or a concentrator source or perhaps a liquid source. The two models we're looking at today are the LTV 1150 and the LTV 950, both models used in the home care setting today. A lot of parents will say to me, I really want the 1150, the new purple one, but the 950 and 1150 both do the same things. What you'll learn today about is the PEEP or positive end expiratory setting. That is what differs between the two machines, and people are under the misconception that if they can actually set the PEEP here on the machine, whereas they cannot do so on the 950, that one it's set on the hoses, that makes a difference for their child. It technically doesn't make a difference for the child and what the child's lung receives for support, but it does somehow add some level of comfort to families when they can see the number directly set on the machine. So we're going to review the 1150 and the 950. And the one thing that I think is most important to start with is, how do I get power to the machine so I know it's going to work? Both machines have an area here, and if you look, it says external power with a light, charge status with a light, and battery level. If I turn the machine on, the battery level light comes on if it's not plugged to anything. And that is only telling me with an illumination of green, amber, or red how full my 1 hour or less internal battery is. So in the rear of the machine, this is the 1 hour internal battery. As you can see, there's nothing else on the rear except the adapter that allows the ventilator to mount onto a pole, for example. This side of the machine has a filter. This filter will collect white dust very often and need to be cleaned. The black cover pops off. You just delicately wipe off the dust and put it back in place. This is the power adapter, so all sources of power for the laptop vent connect directly here, and we'll review some of those shortly. These are other ports for external alarms and connectors to hook up to computers, not typically done in the home. This is our oxygen connector, thus the green cap. This is where we will connect an oxygen hose and give the ventilator liters per minute of oxygen based on your child's prescription and need for oxygen. This is another filter here that filters the air for the air inlet. This machine is its own air compressor. It makes its own air under power. So if your child is not receiving oxygen, the machine can run without an additional source other than electricity. It will make powered air and deliver the breaths to your child. On the front of the machine are where you'll see settings. We'll review the settings as well today. Also, we have some alarms and different features to lock it from little fingers changing things. On this right side of the machine, we have the gas outlet. This is where the main tubing goes to your child to deliver the breath. So we have the exhalation valve adapter here, which will have a small hose on it that goes to the exhale valve where your child exhales out of the ventilator hoses. And we have these two adapters, which I'll show you in a moment, how they connect to the circuitry. And they give the machine information, live feedback from near your child's tracheostomy tube as to how fast they're breathing, the size of their breath, how much air they breathe in a minute, the pressures that they're receiving into their lungs from the ventilator. So these are important connections to make. Above here you see a little round circle and it says, do not block opening, caution audible alarm. So that is where the sound comes out for you to hear an alarm from the ventilator. Obvious reasons you don't want to cover that. With regard to electrical power for the ventilator, we spoke about this being the adapter on the ventilator in which it receives power to run. It does have that 1 hour battery in it, although the company recommends that's merely used so that the machine will continue to run when you transfer from one type of power to another. If I turn the machine on right now, and the machine is not connected to any power, you will see the battery level light come on as green. So my internal battery of about 1 hour is full. This light will change to amber and to red. The machine will say bat low to warn you that that battery's low, and bat empty when it's empty. It will be an ear-piercing alarm that will not stop until you physically turn off the machine by holding the power button down for 3 to 4 seconds. And that is so that no one can walk by and turn the ventilator off and not have you hear that something's happened to the ventilator on your child. The connector is quite delicate. It snaps into place. And although it looks like it sort of slides, it doesn't. It's a push and remove. So all sources of power for the LTV series ventilators will look like this. This is merely the wall plug. It may look like more, but this is the wall plug. And it does have a connection on this side and a connection on the wall. So please be sure that those are connected tightly if you find that there's a power situation with your ventilator. In addition, the Durable Medical Equipment Company, or DME company, which provides you with this equipment in your home for your child, will provide you with a car type battery that's in a plastic case that also has an adapter like this to go to the ventilator. It's recommended that once a month you run your child's ventilator on that battery to assure it's charged fully and how much charge it holds. It should be about 8 hours. It does depend on how much draw from the child's settings on the ventilator, but it should be about an 8-hour battery. You don't want to wait till the middle of a winter storm to find out that it's not working. In addition to that battery, there are portable batteries, which I'll show you in a little while, for when you take your child out of the home on a ventilator. There is a lithium-ion battery that fits in a case very nicely in front of the ventilator that runs about 6 hours. So we will show you that setup later. What we're going to do now is set up the LTV 950 with its circuitry for pediatric in-the-home ventilation with heated humidification and heated wires. There's a variety of circuits for the LTV, pediatric and adult size. There is not a neonatal size. So for those of you that are taking home children from the nursery, you will be surprised a little bit at the size and weight of the hoses as compared to the ventilator hoses that you've seen in the neonatal ICU. But that is what's available for this device. In my opinion, what I've seen here is that this device, with its flow trigger capabilities, is very sensitive to the children's needs for a breath. So although it's cumbersome to have the circuitry up here and to have all those little hoses, this is the closest to the tracheostomy tube and patient in which your child's able to say, I want a breath in, and the machine actually senses that and fires a breath for you. So it's very comfortable typically for the child to initiate a breath and get one immediately, much quicker than when you use your handbag for hand ventilation. You look at the child's chest and you try to squeeze the bag with them. It's very difficult to get one-to-one with them, but the LTV can do that. When the LTV is connected to external power, like I'm going to do right now, we have it connected to the wall plug. What you see is the battery level light goes out because we're no longer using the 1 hour internal battery. We're now using an external power source. Unfortunately, the machine doesn't know what you connect it to. It doesn't know if it's on the 6-hour sprint pack. It doesn't know if it's on the wall plug of the hospital or your home or grandma's house. It does not know if it's on the overnight car battery. It will alarm bat low and bat empty to alert you that the power source it's on has either gone out or is running low. And the green will turn to red. But it would be helpful if you would note what time you start using your battery power, and certainly keep an eye on the overnight battery if you're ever using it in a power storm. Assure that you can hear the alarms from where you are. The Sprint Pack, which you'll see later, does have battery indicator lights on it so you can check and see how much power you have left. So when When I take away external power, there are no lights. When we turn it on, we'll only see the battery level light. That's only indicating the internal battery of the machine. So if you're at home and the machine is running and you glance over and see just the battery light on, something's wrong with the power from here outward. Either the plug has come out, the battery's gone low, something has come loose. And there should be an audible alarm for that, but in the event that you missed it, if you glance over and see battery level, that means you're on the 1 hour internal battery. So let's go ahead and set up the LTV 950 for use with its pediatric heated wire circuit. And we'll set up a humidifier with it as well, heated humidifier to go along with the wires and the circuitry. In the adult population where adults have larger tracheostomy tubes and the risk of plugging of the tube and secretions plugging the tube are less, some of the adults don't use heated wire, but for pediatrics, we do recommend the heated wire circuit when the children are at home. It's difficult to travel with because you don't want to spill water into the hoses and whatnot, but in the home setting, especially overnight, we do recommend heated humidified air with or without oxygen for your child while they're asleep. So in the package, I've opened up the package for the pediatric heated wire circuit. Some come with the heated wire both on the inhale limb and the expiratory limb. This one is just on the inspiratory limb. That is what we use here in this area and we find is more than adequate. So we have this clear adapter that comes in the circuitry. Be careful it doesn't fall out of the package. This is provided so that you can connect the gas outlet of the machine to the inhale limb of the ventilator circuit. What we need to do, because we're using the humidifier today with this 950, we need to get the air, cool and dry gas from the ventilator to our humidifier. This particular humidifier is the Fisher-Paykel 500. Your DME company may provide you with a different brand or model. This one uses a chamber on the top and connects to a sterile water bag. For ventilators with tracheostomy tubes, sterile water is recommended. So we need a piece of hose to get the air from the gas outlet to the humidifier, and they provide that for us. So we're going to connect those. So now the air from the ventilator is going to pass over warm, heated, sterile water, pick up moisture and heat to deliver to your child. This is the other piece that comes in the circuit. It may look a little crazy, but you'll get used to it and you'll be very comfortable with it after a short while. So the longer hose is the inspiratory hose. It has the wire in it. It has a connector for the wire for the humidifier. It has a connector for a temperature probe, both at the outlet of the humidifier and up near the child's tracheostomy tube. That's what helps the humidifier how to work, to tell what the temperature is and to know what to do with the heat and what to do with the wires. So we want humidity to the tracheostomy tube. This is different than the cool mist trach collar that you might have seen, that your child might have used at one point in time. This is humidity like in the air, in the clouds before it rains. So we want this air to go to the lungs 98.6 degrees and fully saturated with water and not rain out in the hoses. In a perfect world, that would be great, but we can't always have that. There are drafts. There are, windows with sunshine coming in. So we try to protect the probes from cold breezes, warm breezes. If you were to put a heated water bag on your child's belly for a belly pain and it happened to come in contact with the probe, that would affect the humidifier. So many factors affect the humidifier, and please do check with your DME therapist if you're having difficulty controlling the water and the rain out in your hoses. So we are going to connect the main hose to the outlet of the humidifier. And we talked about the 3 different hoses that go onto the side of the ventilator and that are very important. If we follow this one, we will follow it along and it'll lead us to an exhalation valve. So when your child gets a breath from a ventilator, it's delivered in through the blue hose, and fresh gas is always going by here, 10 liters a minute of air. So if you're not familiar with that and you think about 1 liter of oxygen that comes out of a meter that you provide for your child, 10 liters of air goes constantly by here. So your child just has to breathe a little bit from here to tell these sensors, I want a breath, fire and give me one, please. The exhale valve is where the child blows out. And a lot of these pieces come apart so you can drain water and do things. What's different about this piece here and the one for the 1150 is that this exhalation valve actually is where you control the setting for the PEEP, or the positive end exhale pressure. There are numbers here that go from 0 to 20 centimeters of water. It's a spring-loaded valve, and we will push on the yellow. It says push to turn, push on the yellow, and turn this to set the PEEP where we want it, between 0 and 20. Most children would use 4, 5, or 6 of PEEP, or positive expiratory pressure. So this will be set here. On the other version that we'll go over in a minute, and we'll look at that one for transport and for outside the home, that one you actually set the PEEP right here. It has a place for it right here. But the exhale valve looks very little different. It looks very similar to this one. It just doesn't have the PEEP setting. What I'm concerned about is that now that the companies are starting to transition from the 950 with PEEP on the hose to the 1150 with PEEP now on the machine, is that if you're, by accident, your DME company sends you this type of hosing and you have the 1150, you cannot set 5 of PEEP on this one and 5 of PEEP on the machine. That will give your child 10 of PEEP. So that is a precautionary thing to think about. Make sure you have the right circuit for your ventilator when you set up the ventilator for your child. When companies are managing both brands, it is possible that you'll be delivered something that isn't correct for your machine. So make sure if you're using the 950 model with external PEEP that you have this PEEP valve, and when you're using the 1150 ventilator where PEEP is set on the machine in this space here, that your expiratory valve does not have PEEP on it to be set, or certainly leave it at 0 if you are using this particular type. If there's an emergency, you need a circuitry. Do not set this PEEP as well. So this hose takes us to the plain hose at the end, and we're going to connect it where it says exhalation valve, and it pushes right onto the machine. The other 2 hoses, they are color-coded. For those of us that aren't colorblind, there is yellow and white, but if you look at them, they only fit specifically onto each one of these in a certain way. What I'm going to ask you to do is turn this, it's a rubber plastic hose, turn it backwards so that when you try to put it on the machine, it wants to go forward. If you just twist from point 0 forward, it may want to come off. And we don't want alarms in the middle of the night because something came loose and frightening everyone. So let's turn them backwards, counterclockwise, and let them turn themselves on and just give them a tighten. Assure that they're straight on and not crooked. And now we have set up the hoses out of the package for the LTV series ventilator with heated humidification. So we went from the gas outlet into the humidifier, maybe a different brand than you see here. We went out of the humidifier, up past the tracheostomy tube, and out the exhalation valve. What we haven't added, but we'll do now, is a few more parts for the humidifier. This one requires a piece to go to the wire on the circuit. And on the side here, it says heated wire. So I'm going to attach the heated wire attachment. And on the ventilator hose, there's a place for the wires to be connected so that the machines can now work together. In addition to that, we need a temperature probe so that we can allow the machine to know what the temperature of the air is. So here we have a connector that says probe, and you'll see there are 2 points on this gray metal reusable hose. Don't throw it out. You can alcohol the tips before placing it in when you change your circuitry. The machine wants to look at the air temperature when it comes out of the machine and also up near your child's tracheostomy tube. So we'll place one end here and one end here. And the circuit comes with this size adapter for these temperature probes, regardless of the brand of humidifier. So we're using heated humidified tubing with heated wires. You can use this without the wires. You will have more puddling. There are circuits with water traps in them for those that don't have heated wires. So there are many different circuits available. Please discuss them with your DME company, your DME therapist, about what best serves your child and your needs for your child. This would be the one that would provide heat and moisture for the tracheostomy tube, reduce secretion thickness and potentially chance of plugging of the tracheostomy tube while on support. When you don't have heated moist air going into the trach, then the lungs have to give up moisture and heat to try to achieve that 98.6 that the body wants, fully saturated with water. So that's why during the day, when you may not be on the humidifier but using other methods of humidification, which we'll talk about, the child may have thicker secretions. It's time for us to look at some of the numbers and settings on the machine. This is the 950 as we've talked about, so the PEEP is set on the hose of this particular model. We have a power button here, on, off. On is one touch, off is hold for 3 or 4 seconds. It will alarm when you turn it off, and you need to silence the alarm to acknowledge that someone has turned off the machine. We have to pick our mode of ventilation. If our child's getting breaths by the machine, mandatory breaths, like for, say, example, 8 breaths a minute are delivered to your child. Are they going to be the kind of breath where we set the actual tidal volume that's delivered to them, or are we going to set a pressure that is achieved in the lungs? All of these numbers are prescribed by doctor's order. These are things that you'll learn before you go home from the hospital. These are things, if you're at home, you'll learn before your child goes onto the device. So these are numbers that are pre-established and applied to the machine. It not only looks like a computer, it is a computer. So there are a lot of internal settings to adjust for comfort of your child on the ventilator. And those will be explained to you as they're determined. They will be something that will be noted in the DME equipment file so that if you need a change out of your ventilator, they can preset the machine that comes to your house in the event of perhaps it's time to change it out to a new one, or if you had an issue with the ventilator, they would know your child's prescription. So we have how many breaths a minute, what type of breath that's going to be. So one of these two will be lit, but not both. If your child is prescribed for a pressure breath, pressure control will be lit at the prescribed number. If your child is prescribed for a volume control breath, meaning that the doctor actually prescribed 300 cc's, for example, a size of a breath that's appropriate for your child's size and weight, then tidal volume will be lit. Over here, more about modes. We have the assist control mode, which means that every breath the child receives is going to be either the tidal volume or the pressure that your doctor prescribed. Now the machine may say 10 breaths a minute, but if it's in the assist control mode, they will get 10 breaths a minute minimum, and any other breath they desire and trigger on will be that set pressure or tidal volume that the doctor has prescribed. In contrast to that, there's another mix of modes we call it mandatory breaths, either pressure control or volume control, and we call it pressure support. So some children receive what they call SIMV, which stands for synchronized intermittent mandatory ventilation. So your child might get 10 breaths of the volume or pressure type, and then in between those 10 breaths, if your child wants to get more air and take more breaths, we can also support those breaths with something called pressure support, otherwise known as BiPAP. Your child may have received BiPAP prior to a tracheostomy tube, perhaps, so you may be familiar with that, perhaps not. But BiPAP is a term that we use when we're using ventilation with a mask on the face. And when we talk about tracheostomy, we usually call it pressure support, and that's what the ventilator says, pressure support. So depending on the child's prescription, certain values will be lit, and the modes will be ordered. All of these numbers can be locked, either for a short hold of the button or a long hold of the button. There also is a panel that can be slid over across the top in case you have other little fingers in your house and you're worried about settings being changed. So there are things we can do to help protect the settings. So we've talked about breath rate, if ordered, how many breaths, what kind of breaths are they. The breath has to be blown in over a certain period of time. If the machine's going to blow a breath in, it wants to know how long do you want me to inhale into your child's lungs. Just like when you squeeze the bag and give your child breaths, we say 1/1000, 1/1000, 1/1000. If your child is a small infant, they may breathe faster and you may squeeze the bag faster to keep up with them. If they're older, they might breathe slower. But the machine needs to know how long we want them to blow in. So an average inspiratory time would be probably 0.6 to 0.8 seconds for a little tyke and closer to 1 second for more of an adolescent child. that will also be prescribed and set. If the child is receiving pressure support in conjunction with the mandatory breaths, the pressure support will be lit here as well. Sensitivity. This is how your child says, I want a breath. It correlates and corresponds to this patient effort light up here. So when I say I want a breath, the light flickers, and based on how easy or hard you've made it for me, the child, I can turn it on. 1 is the very easiest. So your child barely has to move only 1 liter of gas right from here to say, okay, turn on, I want a breath. 9 is the hardest. So you might say, well, Lauren, why would you want to put my child on anything other than 1? Because if you say 1's the easiest for my child to breathe, I want my child on 1. The downside of 1 can be that on 1, if a little water builds up in the hoses and the hose starts shaking a little bit, it can actually tell the machine to trigger a breath. So your child could go to sleep and they normally breathe, maybe they breathe 30 when they're asleep and they're very comfortable. And then you start getting high breath rate alarms from the ventilator. Or yet sometimes people get what's called the apnea alarm, cessation of breathing, because the machine didn't see the patient effort light go on. They didn't sense the child taking any breaths. And that happens because the water in the hoses can, we call it sometimes auto-firing or auto-triggering. The water can actually make the machine, the sloshing of the water, make the machine think that the child wanted some air by displacing air in the hose with the water, and it fires. So we don't want that to happen. If we can get away with a sensitivity of 2, we will do that, 2 or 3. Typically not more than that. If the child has a tracheostomy tube and the cuff is absent or deflated, the air will leak from the lungs out the nose and mouth. And when they go to sleep, they're much more relaxed than when they're awake and trying to play and communicate with you. During those situations, sometimes the low sensitivity or really easy sensitivity of 1 can also, that air leak out the mouth can make the machine be fooled into thinking that your child wants a breath, and it'll start firing faster. So if you notice a higher than normal respiratory rate, especially during sleep of your child, you will see their chest go up and down, and you will hear the machine fire. You will see the trigger light go off, but it's not your child that's asking for those breaths. It's the machine auto-firing. And what we recommend in those situations is to increase the sensitivity just by 1 to see if it solves that problem with the air leak. You may need to put a little more water or air in the cuff of the tracheostomy tube if it's present. Certainly you'll want to drain the water out of the hoses for the ventilator. This is probably the most common situation in which I receive calls from families that either they're getting an apnea alarm or the child's breathing fast at night and they don't understand it. So water in the hoses, potentially an air leak from the tracheostomy tube cuff being down or not being present, too much of a leak. So we can work together to resolve these issues. We can talk about a different tracheostomy tube, one perhaps with a balloon. We can talk about a little more water or air to help resolve these issues. So it's important to alert your nurses as well. When you go home, you're the one that knows your child best. You've been with them in the hospital, you've been caring for them, you've been observing them on their ventilator. And although certainly you'll have registered nurses come to your home to help you care for your child, they may not be completely familiar with this particular brand of ventilator. Perhaps they've had patients with other types. Perhaps they've had patients with tracheostomy tubes that weren't on ventilators. It's important for you to understand that you will be responsible for helping the nurses and other family members and friends that come to help you with what is normal operation for your child with their particular equipment, whether it be the ventilator, the suction machine, the oxygen monitor, many new things to you and your family. We're going to look at the LTV 950 in operation now. What you'll see is that we have a power light as it's on. We are in the pressure control mode, meaning that the mandatory breath rate of 10 is going to fill the lungs up to a pressure of 20, and it's going to inhale for your child 0.8 seconds for each breath. So 10 breaths a minute, pressure up to 20 to fill the lungs, which was predetermined, and inhale time 0.8 seconds, also predetermined by your child's physicians. In addition to that, we have the pressure support illuminated. So we're using the pressure control SIMV mode, meaning that we have synchronized intermittent breaths of 10, meaning that In 1 minute, on a breath rate of 10, typically a machine would fire every 6 seconds. But it's not going to do that, because what if your child's blowing out when it's time to breathe in for them? The machine is going to wait for your child to take a breath only for that 6-second window or so, and then if they don't take one, it will fire. So if your child does not breathe at all, they will receive 10 breaths. But if they're breathing actively, the machine will allow them to inhale and try to give the breath in with them comfortably. So the two of them are together with their breathing. In between those 10 breaths, your child can take as many breaths as they would like, utilizing the pressure support, another predetermined setting which helps them overcome resistance of breathing through a tracheostomy tube with whatever breathing problem that they have, whether it be lung or muscle issues that make it difficult for them to breathe without assistance of the ventilator. The sensitivity you see is at 1, so if I start shaking this hose, the machine's going to fire, fire, fire. I think you can see that in the patient effort window, that it's going to keep giving breath because I'm shaking the hose. So that's just an example of how having it so sensitive is great for the child to be able to get a breath when they want one, but perhaps could be a hazard under some circumstances. So we have 10 breaths a minute. The breath goes up to 20, 0.8 seconds it holds for, and in between the breath inflates the lungs up to a pressure of 15. Now I keep saying up to, what's the down to? So PEEP, positive end expiratory pressure, sister to CPAP. CPAP is when you're breathing on your own. PEEP is when it's a machine breath delivered to you. So we need to set the PEEP, and there is no place to do that here. There's a place to see what it is, but there isn't a place to set it. On the LTV 950, remember we have the circuit that has the PEEP valve in the hose. So this says press to turn. If I press the yellow thing and turn it and look at the numbers, it turns very quietly. If I don't, I feel like I'm going to break it. So you do want to follow the package instructions and push on the yellow, not this, but the yellow, and dial down to approximately, we're going to say 5 for this child, 5 of end exhale pressure. So the ventilator inflates up to 20 of pressure and releases down to 5. And the positive end exhale pressure is to help keep the lung air units open between the breath cycles. If your child's having difficulty with breathing, with fluid in the lungs, with oxygen problems, that PEEP might go up 6, 7, 8. And typically it'll never be below 4. 4, 5, 6 are average numbers. If a child's on 7 of PEEP, someone might question where that came from, why. Maybe they had a little fluid in their belly and it was kind of hard for the ventilator to help them out. But these are all things that you should have learned while you're caring for them in the hospital. And you will be reinforced with these numbers as you learn the ventilator and then see it on your child and get to know what they're all about. We can see the settings up here under the airway pressure window. So whenever the machine goes up and down, you can see it goes up to 20 and down to what looks like 5, between 10 and 0. So there, I can look and tell you, I don't have to look at the valve. I know that we've set the 5 of PEEP here, because it's showing me up to 20 and down to about 5. In this window, I can also look at different values. The first value I like to look at is the PIP, peak inhale pressure. Well, we've told the ventilator to go up to 20 for those 10 mandatory breaths and assist our patient, our child, up to a pressure of 15 when they want breaths. So we should see around 20 or around 15. And this is the window that's reading from these two little hoses up here. So these are not set numbers, they are measured numbers, and they may vary a little bit. Like you see, we have 15 and 16 and 20, 21. Things can be off by just a little bit. These are the settings, these are the measurements, the live measurements. If your child is coughing against the machine, you might see the pressure go way high and say high pressure, and the high pressure alarm is flashing at us. So there are different reasons in which the numbers will change. Whenever an alarm happens, it's visual and audio. The reason why you didn't hear anything right now is because there is a very nice feature on the LTV in which, for children that are very active, cough, turn around, yell at you, whatever, you can silence the audible to the high pressure alarm for 1 or 2 breath cycles before it starts beeping out loud at you, if you choose to have that feature on. And many families do for children that are very active, so that if the child just rolled over in bed and created a high pressure situation, They won't receive the high pressure over 35, which is where the alarm is set for this child. But you may walk into the room and see this going on and you say, wow, I didn't hear anything. That's because it didn't happen a couple times in a row. If it happens once, it resets and everybody's happy. If it continues to happen and there's a reason why it's going off, it will alert you audibly. And this is a feature that can be enabled or disabled. Whenever an alarm goes off, until I reset it, this is the silence reset button, until I hit the button to clear it, it's going to continue to be on the screen. So if you're in another room and you hear an audible alarm and you come into the room where the child is and you look at it, it will tell you what alarm went off. In addition, they will be flashing. So if I disconnect it, you immediately get a couple different alarms. We saw disk sense because the sensors were disconnected. We also saw low pressure. The machine was reconnected. I didn't do anything except put it back on and the noise went away, but I do have to clear the visual. So I'm going to just hit the button once to clear it. If I hit the silence reset button twice, when the red light is on, the ventilator is silenced for a minute. So if you're going to leave the room, you may not wish to silence it in error and leave the room. Re-enable the alarm so that it's on the minute you leave your child's side. So when I push the button and the red light is on, that means that alarms are silenced until they reset themselves. And you don't want to do that if you're not going to be with the child. So we're looking at numbers here. We see that the pressure is 20 or so and 15 or so, just like it's supposed to be. And it did respond to a cough maneuver that we did to show us that it would go up high and the alarm would stop that breath from pressurizing the lungs over 35 centimeters of water pressure. Those will, again, be numbers that you will discuss with your DME therapist. Doctors don't typically prescribe the alarms, they prescribe the settings. And then you and your therapist will talk about what is safe in your home versus what is your child's normal numbers. So if your child normally has pressures in the higher 20s, you may have to turn the alarm up to the higher 30s. It really depends. If their pressure is very low, you might set the high pressure low. So within a range, our standard practice here at Boston Children's Hospital is to set the pressure 5 to 10 above and below what the patient's pressure is within that range. You see it saying high PEEP off. If you've disabled an alarm internally, the machine lets you know. So periodically, if you turn off an alarm, it will tell you it's been turned off. And you just have to touch the button to keep going and seeing numbers again. But it wants you to know that you've internally set something off. You don't see the PEEP alarm here. Like I mentioned before, it's a computer, so there are a lot of internal settings as well. After the peak inhale pressure, we look at MAP or mean airway pressure. There is nothing for you to set or adjust. This mean of 7 just tells me, the practitioner, how much cumulative pressure we're applying to your child's lungs to support them. The higher the mean, the higher the ventilator support. We can look at the PEEP here. So I said to you, well, it looked like it was 5, but the machine's saying it's 4. So we can adjust our valve a little bit to make it more often, say 5. And the PEEP setting is done when you first put the circuit on the machine, when it comes out of the package. No one's going to ask you to chase the number if it says 4545 5656. We just want it to be close to 5. And the circuits, it depends on your DME company, but most recommend the circuitry being changed every 2 weeks, including humidifier parts. So every 2 weeks when you change the circuit, if your child's on support 24 hours a day, you'll use your backup ventilator and change the ventilator circuit that has the most parts, which is the one used with humidification, and then test it, which we'll show you as well. Next comes F, which stands for breaths per minute. And all of these things will be in the manual. They will be in handouts that you'll likely be provided by those that are training you on the ventilator. Why they use some medical terms, I don't know, for parents. But F is breaths per minute. And it does say BPM, which sort of leads you to that. So right now it's telling us that our patient, our child's total breathing rate, 10, the machine's firing no matter what, but there's a total of 20 breaths a minute being taken and received by the child. Then the machine looks at something called VTE, which is exhaled tidal volume. It goes backwards, exhaled tidal volume. So this is the size of the breath that your child is receiving, and it's in milliliters or cc's. So if we say 140 cc's, think about an ounce is 30 cc's. So this is like, what's like 4 ounces, that breath. Think about a 1 liter pop bottle, and think about, half of that is 500, a quarter of that is 250. So if you think about 30 cc's an ounce, it equates to air, if you want to just in your mind to think about how big the breath is. The breath size relates to the size of the child's lungs and the ability of the lungs to let air in. So when we've told a machine we want you to inflate to 20 centimeters of water or 15 centimeters of water, up to 20 and down to 5, up to 15 and down to 5, it's your child's ability to let air in that governs the size of the breath. That's very important, because if the tracheostomy tube has some secretions in it, if the lungs have secretions in it, if the child coughs, they will inhibit the ventilator from expanding the lungs the way they would on a normal resting breath. So this is important to remember. The ventilator is told to go up to 20 and down to 5 of PEEP, or up to 15 and down to 5 of PEEP for pressure support breaths. And the ventilator is going to go up to those numbers regardless of whether the air actually makes it into the lungs. So if I don't let the air into my lungs, it's still going to go up to 20 and down to 5. But there won't be much air given to the patient. And that's where you can see the VTE, or tidal volume, go down, down, down. What we had was a larger, much larger breath. Watch. I let the lungs go. 200, 150, 200, 150. I close the lungs down. I tighten them, I plug the trach tube, the number is going to go very low. Your child won't be getting much air. They will be having respiratory distress. If you have an oximeter on, you will see desaturation and likely change in heart rate. So now you're thinking, well, this is kind of crazy. How am I going to leave my child and not know if the trach tube is plugged? There is a third alarm, and it is, for some people, a little hard to grasp how in which it works, because you're not respiratory therapists and this isn't what you've been doing for your life. But what the machine does is it looks at the size of the breath, VTE, and the next number it looks at the F, how many breaths. So it looks at how many breaths and the size of the breaths in milliliters, and it constantly extrapolates that out into a figure that it looks at, and it's called minute volume. So in a minute, how much air did my child use on the ventilator? Well, if my child's breath is 300 cc's large and they breathe 10 times a minute, then that's 3,000 cc's of air. So it's just math. Right now, we would say that this breath is going between 150 and 250, because we have 2 different size breaths here. We have the mandatory breath, which is more pressure and larger. The machine is multiplying the breath rate and the size of the air and coming up with 3.4 liters of air in a minute that it's seeing your child exhale. These transducers here are watching the air coming out, and that's what they see. Now it's up to 4.4. So if the amount of air that your child's breathing is reduced because they had a plug, for example, in the tracheostomy tube where some secretions built up, this number would drop, and there is a corresponding alarm for it. So in the hospital, we set our alarm. If our patient is 3.1 liters, that's the amount of air that they're using on a given period of time, awake or asleep, whatever it is, we set the alarm half that. So I'm going to set the alarm at 1.5 liters. So 3.1 is what your child's exhibiting that they're using right now based on how many breaths they take and how big they are. And I set the alarm at 1.5. So if this 3.8 drops below 1.5, because no air is getting delivered to them, or less air is being delivered to them, it's going to alarm. The closer you set this alarm to the measured amount, the sooner it goes off. But once this number drops below 1.5, it will alarm and it'll say low min volume. And you'll see that momentarily. I realize this is a difficult concept, and those that are training you will certainly go over this as many times as you need to. So the alarm is flashing, it's audible, And it's saying low min volume because your child's not receiving the amount of air that the machine has seen them been receiving recently. This is most useful during times of the child being unattended and perhaps asleep overnight. If they have a balloon on the tracheostomy tube, it can be raised to help the machine actually capture the air going in and coming out of the lungs. If the tracheostomy tube does not have a balloon on it, then a lot of the air that goes into the lungs will go out the nose and mouth, not necessarily out the ventilator circuit. In those times, this low minute volume alarm may not be as accurate. The volume that you're measuring on the machine may not be as accurate. So really work with your respiratory therapist at home to figure out what are the best alarms day and night. I ask folks to please know their child's breathing rate and heart rate when awake and when asleep. And also the volumes they see on the ventilator. It would be helpful to know what you see sound asleep and what you see awake and playful, because that will help aid you in how they're doing, as well as oxygen. We've talked about the fact that we can add oxygen to the machine right here on the oxygen inlet. It will be by liters per minute, and the more oxygen, the higher the concentration the child receives. You will know before you go home or whenever ventilation is initiated with the LTV, you'll know how many liters gives your child a saturation that is normal for them, typically 92 to 95%, but it depends if they have heart issues or not. But whatever the doctor's recommended amount of oxygen saturation that you look at with your monitor, you will bleed in the amount of oxygen your child needs. Remember that the oxygen that goes in the machine is a fixed number, so you may add 3 liters a minute. But what if the child breathes like they're crying and they're anxious or whatever, they're happy and playful and they're breathing much faster? They will dilute that oxygen. So they may need a little bit more flow from your oxygen source when they're very active and breathing faster. And in fact, at night asleep, they may not need as much. But that number is important for you to know, because if you go home next week, or next week this ventilator is initiated in your home, and 3 liters is fine, and then 2 weeks later, things aren't quite right, the child has a little runny nose, and you're putting 5 liters in for the same oxygen saturation, there's a change. So you want to be able to tell your doctor, not necessarily that my child went from 40% to 60% like we do in the hospital, but that we had to go up from 3 liters to 5 liters. We need more oxygen to get the same oxygen level in our child. There is a change, and it may be something respiratory. In addition to that, the breath rate, awake and asleep, the amount of air they receive when they're awake and asleep, all of those things are tools you can use to help you evaluate your child. The last parameter under the select window of information that the machine receives from these transducers is the ratio of time in to time out. We want to make sure that your children have enough time to blow out before the next breath comes in, and that looks at that ratio. There is no alarm for that. We can hit this button twice quick and it will scroll all those numbers, or perhaps you want to set it on F and watch your child's respiratory rate. And this goes for your nurses as well. They're welcome to look at certain numbers and or have it scroll, or certainly just push the button and find the number that you want. When your child's in a pressure preset mode, the volume, as we showed you earlier, varies depending on how easy or difficult it is for them to let the air into their lungs, so that you may wish to watch the tidal volume to see that they're getting the volumes that you're familiar with, that you're used to. You've noticed that I added a little piece to the end of our circuit here. This allows us to attach the ventilator to the tracheostomy tube rather than attaching this point, which would be very difficult. What I need you to understand is that the fresh air is going round and round here. And the air that's within this adapter, your child has to rebreathe. So they breathe in, they blow out, but they have to rebreathe this air with carbon dioxide in it. So you want to make sure that although you may get things in the mail from your DME company in error, perhaps, larger pieces, be sure that you check with your respiratory therapist about what piece is appropriate for your child. We cannot lengthen this very long without challenging the child to breathe more dead space or air. If you have a large breath like an adult would, then this amount of air in here, maybe 35 cc's of air, isn't going to make a big difference to your size of breath. But if you're 6 months old and your size of breath is 50 cc's, this would be almost half of it, and that would be a lot. So Although you get a lot of equipment that comes to the home, and it would be really nice to allow your child to roll and walk across the room and have a lot of space, we can't lengthen from here to the tracheostomy tube very much without compromising the child's work of breathing. So most people think that if you add the dead space, that the carbon dioxide will rise. In fact, if your brain is working properly, you will breathe harder and faster if someone does that to you. So just make sure that you have the right adapter from the ventilator Y to your child's tracheostomy tube. Now we're going to move over to the LTV 1150, another home version of the LTV ventilator, a newer version. The major difference between the LTV 1150 and the 950 is how it looks at the PEEP. The PEEP on this machine is set on the hose, as we discussed earlier. It's not set on the machine. So these breaths, when you set a pressure breath or a pressure support breath, it goes up to 20 and down to the external PEEP of 5, a difference of 15 centimeters of water. For the pressure support, the doctor ordered for your child to get 10 centimeters of pressure support above the 5 of PEEP. On this machine, the 950, we set the 15, the top number, and the 5, the bottom number. That's because you're setting the PEEP on the hose, and the LTV doesn't know what you set the PEEP at because it's external. That's the major difference, and that's where the most confusion is with the LTV series ventilators. How I set the pressure control, if ordered, how I set the pressure support, if ordered, and where I measure what the right number is. So if your PEEP is external on the hoses, the machine does not know how much you set, and that cuts into the amount of pressure on the machine. So for these exact settings on the 950, this is up to 20 and down to 5, a difference of 15. This is up to 15 and down to 5, a difference of 10. On the 1150, as I'll show you in a moment, we will be setting difference and not the top number. Everything else will look the same. This will look the same. This will look the same. The PIP will be the top number, the 20 or the 15. And that's what you'll see on the airway pressure, because that's what your child's receiving. Up to 20, down to 5. Up to 15, down to 5. Those are the prescribed pressure settings so that your child achieves the right size of breath for their condition. But as I've said over and over again, the other ventilator, the 1150 that you can get at home and the 1200 that you'll use in the hospital, and some ambulance companies also have the 1200, they will set the difference between those two numbers. So for that reason, I'm asking parents to take a photograph of the face of their machine while it's on the child. If they happen to have a smartphone that takes photographs, take a picture of it, so that if by chance your child's only on at night and comes to the hospital during the day but gets admitted for some reason, or comes to the hospital by ambulance and the ventilator is left at home, you can help the practitioners at the hospital identify what actual settings your child is on by looking at the picture of it. We can write it down, we can post it on the wall, but it seems to never make it to the hospital. But on your cell phone, it tends to make it to the hospital for us to see and help coordinate that we get the right settings for your children. So let's move over now to the 1150. We're looking at the LTV 1150 now. With regard to daytime, leaving the home for doctor appointments, leaving the home for the playground and whatnot, the LTV does supply what we call dry circuit. So this is a circuit that does not have the heated wires. It's not going to be used with a humidifier because you're going out. It has the same adapter that goes into the gas outlet. The circuit does come with the short piece, but we're not going to be using it. We're not going to be sending the air from the machine to the humidifier, so we won't be using that piece now. We have the same circuit that you saw earlier. It's all white instead of blue and white because it has no wires in it, so there's no heated portion. So we're going to connect the large hose to the outlet of the machine. We're not going through the humidifier and the heating system. We have our 3 hoses. The straight cutoff hose, if we follow it, goes to where your child exhales. You'll see that that looks a little bit different than the other one. It does not have the PEEP valve incorporated into it. So it's still an exhale valve. It will still have, moisture if it were on a wet circuit, but your child exhales here and the machine will send a signal so that this red rubber valve will either stop the air from coming out so that it inflates the lungs during the time it's told to, and then release. And this connection to the machine tells it what to do. We're going to connect this to where it says EXH valve and make sure it's secure. And then we have our other two pieces, which are brains of the machine, which send feedback from up near your child's tracheostomy tube back to the machine, color-coded yellow for the middle one. We talked about turning it backwards or counterclockwise so that when you connect it, it wants to go forward, and just give it a little tighten. And these will look at the child's breathing rate, measure the amount of air they're receiving. There is a pre-use test, a tightness test for the device. It is in the manual and it should be taught to you. And I'll just explain it as we do it. We hold down the select button up in the window. Hold it down, don't let it go. Hit the on button. We wait until it says remove patient. Okay, remove patient. We don't have it on our child. We can't do that on our child. What do you do when you hear a noise? You silence it. We're now in the vent check mode. We're going to use the set value knob and the select button to go through a certain series of ventilator pre-use tests. If we want to, we can check the alarm. Now I can't silence it now because I'm testing it. I can't silence it. The next one is the display. We can see that all the lights are functioning. The third check is for the controls. If I want to, I can see that that's breath rate, and that's tidal volume, and that's pressure control, so that they're all coordinated properly. And the last one, but the most important one, the one that everyone is getting into this menu for, is the leak test. You want to know that you set it up properly and there's no leakage of air out the circuitry. For obvious reasons, without the humidification system, there are very few connectors, so the chances of leak are much lower. But you want to assure that the exhalation valve is working properly as well. So what it will tell you in the manual is to now cover the patient Y with a glove, would be important for infection control reasons. Cover the hole that you do have, hit the button one more time, and now we're in the leak test. It's going to look at its turbines. This runs hot in the front here. This is a special material that's used on airplanes to dissipate heat. Then it's going to do a pressure tightness test, usually in the 50 to 60 range, and it's looking for air leaking out. If we don't leak out 1 liter of air somewhere, we will pass. Leak pass. Good to go. What if we fail? We can tighten all the connections and push the button and go around again. Go around all the way to leak and do it again and hope that we pass. If continually we've tightened things and we can't find the leak anywhere, we're going to try a different circuit. So you see it does a pressure check, then it looks for a leak in liters per minute coming out somewhere. So if I make a big leak, you'll see it. And now we pass. We cannot put this on our child now. There's no flow. It's not on and running. So what I ask folks to do is just turn it off. Hold the button down, turn it off. Silence it, as you always need to do when you turn it off. This is normal for the vent in-op red light. It's in the manual. It's normal for this to be on for a few minutes after it's powered up, as well as the charge status light. When you plug it in, it determines whether it needs to send power to a battery source that's on it. What you're going to notice right away is that this looks a little different than the last ventilator we were reviewing. And what's different is right here. We have the PEEP set right on the face of the machine, so it's an internal setting. What that does is it changes how we set pressure control and pressure support. Because now that the machine knows, for example, our patient has been using, or our child we've been talking about, uses a PEEP of 5 and had a pressure that went up to 20. Up to 20, down to 5, difference of 15. The difference is what directs the ventilator to expand the lungs. How much? If we need more, we go up. If we need less, we go down. So when I turn this machine on, you're going to see that this one, even though it says pressure control plus PEEP, pressure support plus PEEP, it doesn't say that on the other machine. When we turn this on, so see, we've got battery low and we've got amber in the window. So we are on the battery level, the internal 1-hour battery. It's telling us it's low and it's amber. So I need to plug something into it. I didn't plan this, but it worked out very well for our video. What I'm going to show you is, for travel, there is a knapsack, or excuse me, I guess it's a bit more of a case, carry case. The battery fits right in the front here. It's called the Sprint Pack. Sprint Pack. It is 2 3-hour batteries, all in sequence. There's a button that you can test and see how full they are. The Sprint Pack is the portable battery for the LTV series ventilator, which fits in the case that I showed you. It mounts in the front of the ventilator here, and the power will be connected, as all the other power connectors are, to the ventilator. You'll notice when I plug it in, the ventilator changes over to external power and is charging the internal battery now. We don't have the battery level on anymore. I can reset this. We no longer have that low. You also might have noticed that it said power lost. When you connect and disconnect power sources from the machine, it also lets you know that you've disconnected something. It's again telling us battery low. So the audible has gone out because we now have external power and adequate power for our patient. I can reset the alarm. The alarms will, because there's only one place for an alarm, the alarms will sometimes layer, and you may have to reset the alarm more than once to get rid of the layers of alarms that are there. So we're now running on the Sprint Pack, and we can see how much power is in the Sprint Pack each side by holding down the button. The Sprint Pack would then connect directly to the ventilator plug and would charge both, run the ventilator and charge the Sprint Pack at the same time. So it's important when you're traveling to take your ventilator plug with you so that you can charge your battery if you need to, or run your ventilator if there's any battery failure. We are now looking at the LTV 1150 with the same settings as we had on our patient on the 950 ventilator, but what you notice are different numbers here under pressure because our PEEP is now internally set. So our child that was on the 950 ventilator that we demonstrated a few moments ago was on up to 20 and down to 5, a difference of 15 centimeters of water. On this machine, we set the 15. The pressure support on our other ventilated patient was up to 15 and down to 5. Amount of pressure support or help for the breath size was 10 centimeters of water. We're actually setting the 10. What you'll notice is that up here in the airway pressure display, we're still going to see up to 20 and down to 5, and up to 15 and down to 5 for these two different types of breaths. And the reason for that is what your child's receiving. If your child's on 20 of pressure control, it's up to 20 and down to 5 of PEEP. If they're on 10 of pressure support over 5 of PEEP, that's up to 15 pressure, down to 5 pressure, up to 15, down to 5, and the amount of air that they receive depends on their ability to let air in. It's been prescribed for them, those amounts, based on what was observed by blood tests, non-invasive monitoring, and whatnot that was appropriate for them given their type of breathing problem. What you might notice here is that this 10 is flashing, and that is one of the internal settings for pressure support ventilation. Because pressure support is what we call a spontaneous mode, we don't tell your child how many pressure support breaths they're going to get. They take them whenever they want them. So if they initiate a breath and trigger a breath, you see the trigger light going off, they will get one. If they happen to have a leak because the cuff or the balloon on the tracheostomy tube is deflated so they can phonate, or they don't have one at all, if there's a larger leak of air coming out the nose and the mouth, the machine doesn't know when your child's done with that breath, because we have inhale and then they go to blow out, but if some of it's coming out the nose and mouth, the machine can't sense that. So under the internal settings of the machine, we have set a timeout for that breath. And the 10 is flashing because right now, from whatever the characteristics are of my child here on this ventilator, it needs to time out because the child must have a leak out the nose and mouth. So if you call me and tell me that the 10 is flashing, I'm going to say, well, that's okay, because you don't hear an alarm. It doesn't mean that something's wrong or bad per se. But if I thought your child really needed the full 10 of support, I might say to you, well, put a little more air or water in the tracheostomy tube cuff when they're sleeping. When they're awake, they would generate. Typically, when they're awake and they're breathing, they generate the breaths, and it doesn't necessarily do that. But we hear more comments from folks that 10 is flashing or the pressure support number is flashing when they're sleeping and when the cuff is deflated or if it's absent. So we can just talk about it so you'll understand why it's happening and what the precaution is. The last thing that we did not discuss, if my child stops breathing, what happens? Well, if your child is like this one and on 10 breaths per minute, they're going to receive 10 breaths a minute whether they initiate a breath or not. But if your child is not on a breath rate, so I'm going to turn the breath rate off. So all we see right now is the pressure support breath. So this person, this patient, this child is on what we would call straight pressure support. You might refer to it from terminology in the past as BiPAP, but it's bi-level support via tracheostomy tube, so that we're going to have a breath in and a breath out, a top pressure and a bottom pressure. I should mention that the LTV ventilator can also be used non-invasively. So we could use pressure support or BiPAP with a mask on the LTV. That may be done with your child as well. They could use a nose mask or a full face mask. Some practitioners are now using cannulas to ventilate, to do CPAP at least with this ventilator. So a trach isn't always the only route of administering ventilation to your child. If your child is on a mode of ventilation in which they are responsible to take every breath, like pressure support or otherwise known as BiPAP, there needs to be a way in which the machine can respond if they stop breathing. The way in which the laptop vent does that is we set an apnea or a cessation of breathing delay time. So I can set 10 to 60 seconds. If your child doesn't initiate a breath and isn't seen triggering a breath like I am doing right now with the ventilator, it will go into backup ventilation. And what it's going to do, this will light, one of these will be lit depending on which one down here is lit, and there'll be an inspiratory time, and this goes out. So it's going to actually fire preset 12 breaths a minute. And you'll have to talk with your practitioners to see if 12 breaths a minute is enough, because there are other ways to finagle that. But what it'll do is fire 12 breaths a minute of the mandatory type of breaths that are set on the machine. So it is important to assure that these are in the right place for your child, because if it went into the apnea backup ventilation, you'd want to make sure the machine was going to fire in a breath that was appropriate for your child's size. And if you push the manual breath button, you get one breath of that type as well. So it's very important to have these set properly, even if you're just using straight pressure support. In addition, I think I mentioned earlier, there's a control lock button which you can turn on so that if someone tried to turn a button, it would say locked. That can be turned on and off. So I'm going to stop breathing so that you can see that once the machine has violated the apnea time period set internally, there are a lot of internal settings because it is a computer. You will see it will alarm audibly. It'll say apnea 12 breaths. This light will go out. These lights will come on. If the noise is enough to startle the child to breathe, once they take 2 breaths, it automatically resets and goes back to the straight pressure support setting they were on. So what you're seeing now, you heard the audible, you see apnea 12 breaths. The pressure support went out. The mandatory breaths are firing. This is the up to 20 down to 5 or 15 of pressure control over the 5 of PEEP, 12 times a minute. Once the child takes 2 breaths, this goes out. They're back in pressure support where they were, but it's saying apnea. So if you're in another room and you come in and you see it just saying apnea, the child violated the apnea timing, but started breathing again, and it's gone and reset since you got there. This is one of those potentially common things that can happen during sleep at night when water builds up in the hoses or there's a cuff leak of air coming out the nose and mouth. When the machine fires extra breaths, it sort of blows down the child's carbon dioxide and reduces their drive to breathe, thus causing an apnea situation. So there is a backup ventilation system in place for your child should they not breathe on the ventilator. If this is happening, please do discuss it with your practitioners. Perhaps the sensitivity is too high and needs to be reduced. Maybe they can't trigger the breath when they're sleeping because they're just that much weaker. We all breathe a little bit less when we're sleeping. So look into different reasons why that might happen. As in all other situations, you can just clear it with the silence reset button and go back to standard ventilation that you were at. When you're traveling, as we have this set up now with the dry circuit, it probably is advisable that you utilize an HME, the nose heat moisture exchanger. They come in many different sizes. This is a piece that will be placed between the ventilator and the trach adapter. And remember, this will add, again, more space between the fresh gas and your child's lungs. So we want to make sure it's appropriate size. They come in neonatal sizes, and this is an adult size. They also come much larger. So let's make sure that what gets delivered to your home is the appropriate size for your child's size of breath and humidification needs. While using the HME, which has the paper in it that captures heat and moisture from the air that you blow out and gives it back to the next breath you take in, it's trying to reduce the humidity deficit of not having a heated humidifier in the circuit. So your child may require more frequent suctioning, maybe some saline installation. They may have thicker secretions while they're using the HME. But they are successfully used by children and adults in the world daily to go to school and be active out in the world and not be tied to the ventilator at home. So please do talk with your practitioners about using the HME to get out of your home, and you can work on your child's tolerance of timing with it and whatnot. You can make sure that you have extra saline with you if you need to do something for thicker secretions, and always have your spare trach tube with you as well. So thank you very much. I hope this has been helpful to you. Good luck. Hi, I've provided you with an awful lot of information today about the Pulmonetics series ventilators. Let's review one last time the alarms. We have the high pressure alarm, which remember is always visual and flashing, but won't necessarily be audible if you have that high pressure delay of the audio enabled. That's a deep menu internal feature that your DME company can enable for you. And it means that if your child coughs once, the machine will limit the breath at the high pressure limit setting, but you won't get an audible alarm unless they cough a couple times in a row. So this allows for a little bit quieter household when there might be just a little rustling around. We also have the low pressure alarm, which is set externally on the machine, and that indicates that the breath did not go past the pressure that you have set. So if your child's on up to 20 and down to 5, and it's set at 8, if the ventilator doesn't go past 8 when it's delivering a breath, the alarm will go off low pressure, typically for disconnecting of the circuit. But you do want to have the pressure set high enough so that you'll assure the patient gets some breath before the alarm will be enabled. We also have that really tricky alarm, low minute volume, on the face of the machine. And remember back we talked about that this alarm is looking for, in the parameter window where it says VE, that's minute volume. So the machine is constantly looking at breath rate, or F as it says in the window, times VTE, which is the tidal volume of each breath. So if your child is breathing 10 times a minute and their breath is 100 cc's, that would be 1,000 or 1 liter in the VE window. The alarm would then be set at half that number. So the low min volume alarm should be set half than the measured VE. Another thing to remember is if the tracheostomy tube cuff is deflated or absent, the machine cannot always register air that is going back out of the circuit, out of the lungs and into the circuit, because some of the air will go out the nose and mouth. So look and see what your child's VE in the window is reading and set the alarm below that, so you'll be notified if the amount of air that they're receiving is reduced for some reason, typically secretion buildup. We also have a high frequency alarm or high breath rate alarm. That's not something you set, that's internal, and it could be set by your DME provider. It goes up as high as 80 breaths a minute. So think about how fast your child breathes when they're awake and playing versus asleep, and set that appropriately. It's like setting the alarms on your oximeter for heart rate. You know what your child's heart rate is sort of awake and asleep, and you set the alarms around that. So set a high respiratory rate where you are most comfortable. It's an internal setting, but in the window it will say high F, and it will alarm audibly. There is also a high PEEP alarm that can be set as high as 20 centimeters of water, and it's typically set a little bit generous because with just some coughing, if it's set too close to the PEEP, if your PEEP is 5 and you set this alarm at 8 or 9, it will go off quite often. So it's generously set above the number of the PEEP. It's really there for kinking of an expiratory limb, but like I said, it's very sensitive. And you do already have the high pressure alarm, don't forget, that will stop pressure in the whole circuit at whatever number you have set. It should be raised to that point for any reason. That again is an internal alarm, the high PEEP. You have apnea 12 breaths, and that's only for patients that are not getting mandatory breaths in the machine. Not getting breaths probably, below 8 breaths a minute. So if your child's on a breath rate of 10, 1 breath every 6 seconds, you're not going to have an apnea alarm. But if your child's on straight pressure support or CPAP, where they generate all the breaths themselves and the machine just counts them, if the machine doesn't see them initiate a breath within the time frame that's set on the internal menu for apnea or no breathing triggered, the machine will fire into the apnea ventilation mode. It will say apnea 12 breaths. It will turn on all the mandatory settings. So remember, it's important to have the either pressure control or tidal volume set appropriately for your child's size and weight, so that if they do cause the apnea alarm to go off, they get appropriate settings. You may say, my child doesn't have apnea. That may very well be true. But if your child's on pressure support and the water builds up in the tubing, we talked about the machine doing these like auto cycles where they're sound asleep, and because some water builds up in the hoses and it starts sloshing the hose, the machine is so sensitive that it starts breathing well over what your child's breath rate is. And your child may feel that air. The body senses it and pauses for a minute because it hyperventilated them. So that's one of the nighttime complaints that we have sometimes, is that the machine auto cycles. That's why you have that high breath rate alarm, to alert you. The only thing really to worry about or be concerned with, if it says HW fault, hardware fault, it will tell you in the book, in the manual, to reset the alarm and put the patient back on the ventilator. If it happens again, it needs to be pulled from service and changed out to your backup ventilator, or you need to hand ventilate your child if you don't have a backup ventilator. Typically, children that are on ventilators 24/7 will have 2 machines, one for backup and one for primary use. So please do use your backup ventilator and notify your DME company to change out that ventilator that said hardware failure or hardware fault. The other alarm that you'll see is DISC/sense. And those lovely lines, the 2 lines that you have to make sure don't get wet, that go from the side of the machine up to the hoses, right up near the tracheostomy stoma, they need to remember, keep it upright so water doesn't fill them. If they're kinked or full of water, it will alarm DISC/sense for disconnected sensors. That also will come up if you disconnect off the ventilator. So it's very important to understand what these mean so that you know what to do to resolve them. First and foremost, when an alarm goes off, look at your child's face. Look at your monitoring that you happen to have, your oximeter that's around, and see if you can notice something that's not quite right. People do tend to always hit the silence button and then look at the child, but it's important to address your child's needs before you address the ventilator alarms. Thank you.